Hi, everybody. Welcome to another episode of We Talk Science. Today, I have with me Dr. Teresa Franklin from the University of Pennsylvania in the USA. Hi, Terry. How are you?
Hi. I'm so happy to be here and sharing on We Talk Science. I think this is a great concept for a way for scientists to be able to talk freely, but also I think it's great that you have the references in the post, so folks can go and check and make sure that everything they said is cool.
Yeah. Thank you so much. I think that the whole concept of evidence-based science and of making a blog, basically a blog about that is incredibly important to make sure that we know what the reality is and not to listen to misinformation. Well, that is the hope anyway. So, Terry, you are a professor at the University of Pennsylvania, and you are in the Department of Psychiatry. Can you tell me a little bit more about your journey to where you've been until today?
Yes. So I'm a neuroscientist. I earned my degree in 1999 at Hahnemann University, which is also in Philadelphia. And since then, I've spent most of my time at the Center for the Studies of Addiction, which is, like you said, in the Department of Psychiatry at UPenn. And during that time, I've um, focused on something called conditioned responding using brain imaging tools. And what is conditioned responding? It's basically studying drug cue induced craving, which is a major motivator to use drugs once someone becomes addicted to drugs, and can often and does lead to relapse, which is a big problem. The problem of addiction is relapse, because a lot of people want to quit once they've gotten into the grips of addiction. They've been addicted for a long time. It starts to control their life. They wish they could stop. They do stop. They think they can continue to be free of the drug. And then they're faced with these reminders, things in their environment or feelings within themselves or friends or anything that was previously associated with using the drug, that these things start to gain significance for the person, and that happens in the brain. And they gain so much significance that other activities and other things that don't include the drug become less important. And so these are called drug cues, and they lead to craving. And then the only thing the person feels like they can do to relieve these intense, miserable cravings is to use the drug, and that's a relapse.
So this is really interesting. So when you talk about addiction and cues and what you actually mentioned, how much of addiction comes from the environment, and how much of it is genetic? Is there a genetic component there at all?
There's a very, very strong genetic component. And in fact, our work has shown quite a bit of that. Um, I would say the three major components are genetics, early childhood exposure to drugs, because when children are young and the brain is young, it's very malleable. And once these pathways are established, it's really hard to break that cycle. If people start using drugs, alcohol, cigarettes, whatever, when they're older, it's easier to stop. But when people start using when they're young, and there's a direct correlation between how bad it is, how bad the addiction is, how easy it is to relapse, and how young one starts. And then the third important variable is whether or not the individual has been exposed to trauma. So trauma is a big predictor of someone who uses drugs becoming addicted. So only about 10 to 20% of the population struggle with addiction. Most people can use a substance, an addictive substance, sometimes their whole life, and never become addicted. Um, it's
Hmm.
this 10 to 20% of people who have, and this is generalizing, but these three things come together. They have the genetics, they've had early exposure, and they've had trauma. And trauma can be in the form of, to children, it can be sexual abuse, it can be physical abuse, it can be emotional abuse, it can be, a combination of those. But if someone endorses that they've had trauma, they normally have a harder time. They struggle harder with addiction.
Okay, thank you. So, I mean, my next question is, if you talk about if the three things come together, I mean, obviously, all three of them need to exist before somebody can actually get truly addicted to a substance.
No, no. There's so much
Why should it be
individual.
simple, right?
Right, it's not. It's that's the problem of addict. That's another problem of addiction in my view of how to treat it. How do we treat addiction? It's not a simple pill. It's not a simple pill per drug. It's not a simple pill based on your race or your ethnicity or your sex or anything else or your genetics. It's a very individual. I think we need individual treatment strategies for every person based on taking a family history, learning what works for these people, what are their triggers, what causes them to go back to drugs, what works for them when they are able to maintain abstinence, and all of these things are important. And no, you don't have to have all those, the three sides, the 3 points of the triangle to, and that would automatically make you an addict. There's so much that we don't know, but that's generally, the three things that make you more vulnerable. And the genetics are tricky. I Let me start off by talking a little bit about the brain, because that's what I
Hmm.
study, is the brain. So,
Okay.
and before I even talk about our experiments, let me just introduce you to this concept, which everybody's heard a little bit about or a lot about, depending upon your background, and that's the different neurotransmitter systems in the brain. So there's several of them, and they all work generally the same way. So there's the dopaminergic system, which is the one we're going to talk about. Everybody's heard about dopamine. Then there's the serotonergic system, serotonin. Everyone's heard about that. And there's also other systems, the GABA system, the excitatory amino acid system, the noradrenergic system, which is the fight or flight response, all these different systems. And they're all involved in psychiatric illness, and addiction is a psychiatric illness. And, but the main player that we seem to keep coming back to is the dopaminergic system. And this system consists of basically three parts. Three, to make it simple, it's three parts. So you've got your first of all, you've got brain transmission. So a message has to be transmitted in the brain. And it's transmitted from one neuron, let's say this is the pre neuron, to the post neuron. And the pre-neuron and the post-neuron are separated by something called a synapse. Now, that just means a space. And it's a space where the presynaptic neuron releases a chemical, in this case, dopamine. And the dopamine binds to receptors on the postsynaptic neuron that send the message. So there's an electronic message that's sent down this neuron. It's released, the chemical is released into the synapse, and then the postsynaptic neuron accepts the message and sends it along. So what's important here are three different sort of parts of the system. Are the synaptic vesicles that are released at the neuron, at the presynaptic neuron, and then these receptors on the postsynaptic neuron that accept the chemical. And then there's these things called transporters, and they're all over the place,
Hmm.
but they're mostly on the presynaptic neuron, and they take that dopamine back up. They remove it from the synapse. And that's important because otherwise the message would just continue and continue. And whatever message it is that the brain is having, we all just be walking around like this. So the chemical is taken back up. Yeah. It's the message. So the message ends. So let's talk about cocaine, because it's a very simple mechanism in the brain. So when someone takes cocaine, what happens is more dopamine is released from this presynaptic neuron into the synaptic cleft. And that then acts on these postsynaptic dopamine receptors to really enhance the signal. There's an enormous amount of dopamine released, 4 to 5 times as much as is released when we eat something we really like, like double chocolate
Hmm.
ice cream with double chocolate syrup and nuts and the whole deal. Even thinking about it releases dopamine, right? Well, cocaine can magnify that, and some other drugs even a lot more so. But anyway, so this huge amount of dopamine is released, and cocaine blocks that transporter that reuptakes the message. So the
Hmm.
dopamine is left out there for a long, long time. And what it does while it's out there is increase the importance and salience of the feelings that the person is, they're feeling like, man, I have so much attention. I feel great. I'm on top of the world. Everything in my life is good. I feel good. I look good. Everything's working for me.
Hmm.
That's what happens. So what happens though is that the brain says, oh man, that's way too much dopamine. I'm not used to that much dopamine. I can't handle that much dopamine. So it down regulates, or it over time, there are less receptors here because the cocaine is
Uh-huh.
blocking more dopamine. So there's less receptors on that postsynaptic neuron. And there's the transporters, they're out of commission. They don't even work anymore. So everything becomes dysregulated. And the brain is trying to maintain homeostasis. So it tries to accommodate this. And what happens to the person, what they feel when this happens, is tolerant. That means now I need more cocaine.
Yeah.
I need more
Hmm.
cocaine. I need it more often. And I don't even feel as good as I used to feel. I just feel better than I do when I don't have the cocaine. And if I go without cocaine, the brain is now screaming. It's in a new homeostatic, place, and it's screaming for cocaine because it's used to cocaine, so now it wants it to be there. And it takes time for the brain to get back to a normal place, and it's a long time. And withdrawal can last, depending upon the drug, it can last. We used to think it was short lived, that it was only withdrawal only lasted as long as the drug was in your system. But no, we know a lot more about
Uh,
withdrawal, and it can last days, weeks, months. And what's called psychological withdrawal can last years. And what is psychological withdrawal? That's something I want to talk about. That's when we talk about conditioned responding. And that's what I study, which is the cue induced craving. Why can that come on years later? How does that happen? So what happens when I use the drug? And I'm going to talk about cigarettes because that's my baby, and
mhm.
it's easy to understand because people have a better understanding of smoking cigarettes and what it does. A lot more people can smoke. It's more available. It is the highest of
Yeah.
the addictions. Um, well, I don't know now, but it was for many years. It's going down, which is a good thing. But with cigarettes, over time, when you continue to smoke and you're inhaling the cigarette and flicking the ashes and enjoying the cigarette and hanging out with friends, all of those things start to gain more significance because they're paired with smoking and nicotine. So nicotine is a psychoactive substance that increases dopamine in the brain. While it's doing so, it's
Right.
these all these things that happen while you're smoking gain more significance too. They can gain so much significance that they can even act like the drug years later. So that's what I'm referring to as
Right.
psychological withdrawal. So here's an example, and this is what got me into the field. This is what drove me from being a stay-at-home mom with a chemistry degree, but I was basically staying home, taking care of my three kids, and my brother, who is what got me into this field. From an early age, from the age of probably 12 or 13 years old, I watched my brother become very sick from addiction. We had a lot of addiction in our family.
Mhm.
And the first time I saw him doing something was I saw him sniffing airplane glue out of a paper bag. And I was younger than him. I was like, what the heck is he doing? From there, he moved on to cigarettes and drinking beer and smoking pot. And by his early 20s, his drug of choice was crystal meth. And by this time, he had been in trouble his whole life.
Mm.
And he had the three parts of the triangle that I talked about earlier. He had childhood
Mm.
trauma, he had early exposure, and he had the genetics. So down this path he goes. By the time he was 30, he was in the hospital. He had a serious infection throughout his entire body, including his heart, his lungs, his leg, from using a contaminated needle. And I used he went into the hospital, and I visited him every day. And the first couple weeks, he was out of it, completely out of it. And so he told me what his life was like. And he told me that basically he sat on his couch in his living room every day, and his clients would come to the door to get their drugs. And at this time, he was selling cocaine. And sometimes they would bring him food, and it was the only way he ate because his leg was so infected. That's where he injected his drugs, was his leg, that he couldn't get up off of the couch. His leg, he weighed about 85 pounds at the time he was admitted to the hospital, and half of that was his leg.
Oh
His
my
leg
God.
was huge. He had 2 injection sites, one on the inside of his knee and one on the inside of his ankle, huge open wounds where he injected. He had a bottle that he kept under the couch to urinate in. Every few days, if he had to make a BM, he had to use his elbows to crawl up the stairs to use the bathroom. That was his life. I'm thinking, why would somebody give up everything good in their life to have this for a life? So a few weeks after he was in this delirious state in the hospital, he started to come out of it. And one day, I'm sitting there, and it's about 10 minutes to 1 in the afternoon. And he starts to get really agitated, and he's staring at the clock, and he's starting to sweat, and he's getting angry, and he starts yelling for the nurse to bring his medication. And he had an IV in his arm with a medication coming into his arm, and that had been empty for quite some time. So the nurse comes in finally, and he's like, so frustrated by that point. And I'm like, what's going on here? She starts the medication and leaves the room, and I watched my brother get visibly high, and he starts smiling, and he's like, his
Oh.
eyes, his pupils got small, and he's like, hey man, everything's cool now, da-da-da-do. And I'm completely naive at this point. I walk out into the hallway, and I say to the nurse, what's going on? My brother's an addict. What did you give him? He can't have drugs, because that's how I was thinking. He can't have drugs. She says, all I gave him was antibiotic. That's what he got, antibiotic. And I said, but he's high. I'm watching him. He's high. And the drip of the antibiotic into his veins had gained the properties of the drug enough that he got high. Now, I watched this over the course of the next 2 or 3 weeks, and each day it was a little less until finally it extinguished. The last day that I went to see him in the hospital, he wasn't there. He had checked himself out. He wasn't getting high anymore. He was able to walk by this point, so he checked himself out. And, excuse me, but he died a year later from drug addiction. So just give me a second. You can cut this part out. So that's when I made the change and the choice that I needed to learn about this. I needed to learn what caused people to do this. And I'm really sorry that I'm choked up. But anyway, so then I went back to school. And since my degree was in chemistry, I needed to get some more biological courses under my belt. And I took a year of courses, and I applied, and I got into school. I was lucky. It wasn't easy to get in. And doing my graduate work, I got in with a really good group that were studying conditioned responses, which is what I wanted to do. And we were studying it in animals. And my goal and my dream was to work with 2 people in the field, Anna Rose Childress and Charles O'Brien, who are experts in this field still to this day. And I got in to work with them at the Center for the Studies of Addiction. And, that's where I've been ever since. So that's how I got into the field. And once I got into the field, my first group of studies were looking at conditioned responses in rats. So our experiments they seemed complicated to me at the time, but they're pretty simple. You have basically 2 groups of animals, and you treat all
Hmm.
the animals the same way, except one gets drug and one doesn't. So every day you give animals drug, however you give it to them. You can either teach them to self-administer it themselves, or you can inject it into them, either into their brains or their bellies. And we did all these different types of things. But basically, they get drug, and then you put them in an environment and you watch their behavior. And you
Okay.
watch the drug response, how they respond under drug. And then the other group you treat the same way, only they get a saline instead of drug. And then you can
Hmm.
sort of tell, what behaviors are related to the drug. And then on the last day, you do everything the same way in the experiment, except the animals that got drug get saline. Okay, so now they're getting
Uh-huh.
all of those cues, all of those conditioned reminders, but without drug, and they respond
Hmm.
as if they got drug. Then you take their brains
Interesting.
out. Unfortunately, we have to sacrifice these animals, but we love them and care for them and take good care of them. And, then we sacrifice them and we study their brains. Or we can,
Hmm.
well, that's basically what we do in animals and we found out that there's these certain brain regions that are shown repeatedly to be involved in this conditioned response. And there's certain other brain regions that seem to be not involved, that almost turned off. So then I moved over to the Center for the Study of Addiction, and that's where I started working in humans and using brain imaging techniques, which were just starting to be, you know, uh, coming around in the 90s and the early 2000s. It was like a brand new tool. Everyone now has had an MRI, or knows at least what an
Yeah.
MRI is. It shows you the inside of the body, which is so phenomenal, but back then it was our first time we were using this tool. And we could actually use it in real time. We learned we could have people, you know, participate in simple tasks. You can't move your brain or your head, so it has to be a really simple task, but simple tasks. And we could see
Yeah.
what happened in the brain while they were, engaging in this task. And so our tasks were showing them, let's talk about people who smoke cigarettes, for example, things that remind them of smoking, like individuals smoking and enjoying their cigarette, and then we image their brain while this is happening, and we see these same brain regions that activate in rats when they're given cocaine and then not given cocaine and these conditioned
Right.
responses. We see the same thing in humans. These same brain regions activate.
Wow.
So I was so excited to be able to do my experiments first in animals and then translate it over into humans. So these
Right.
brain regions, what are they? These are limbic regions. They're very, very deep in the brain. They're regions involved in emotion and regions involved in motivated behavior and regions involved in not just motivated behavior, but behavior that's important, right? So I use
Hmm.
cocaine or nicotine and it makes me feel great. That becomes important to me. So that's when the
Hmm.
dopamine shoots up. So the final common pathway of every drug of abuse is this dopaminergic system and the ventral striatum, and um, different brain regions that connect very closely with the ventral striatum. You've, just to throw a few out there that you don't need to remember, but the insula, the amygdala, the ventral
Yeah.
tegmental area. All of these regions are highly involved in allowing us to attribute salience and importance to activities that do well for us. And then what we also noticed was that other parts of the brain, these parts up here in the cortex, these cognitive control regions seem to be inhibited. And so
Okay.
um, we've shown this sort of brain signature of drug cue induced craving, and it's pretty much the same. I mean, with a lot of individual variability with
Yeah.
all people and all drugs. So it's a sort of
Yeah.
like the common denominator. So then we started fiddling around. Two things happened, but the first thing is we noticed that there was a lot of variability among people. Some people didn't have
Hmm.
a response to the drug cues, and we're like, well, maybe it's the wrong cues, and we making drug cues for different people is hard because everybody has their own way that they use drugs and their own friends that they use drugs with and their own internal feelings associated with drugs. It's a difficult thing, but we worked really hard on it and thought we had a good handle on it. And we still saw this variability. Some people just didn't have a response. There's a lot of reasons for that, but the reason that I'm going to focus on right now is genetics. So what we
Okay.
noticed was that, or what we hypothesized based on the literature and based on what we had seen, was that there was something different about these people that were responding really strongly to the cues, and maybe it was in their dopaminergic system. So we started
Hmm.
looking at that transporter. So if here's our presynaptic neuron, our postsynaptic neuron, and the transporter is the thing that takes up the dopamine, we started looking at a genetic variant of that transporter that the evidence suggested people with a certain variant had less transporter and other people had more. So there was a difference in the amount of transporter that you have, which would make a difference in how rapidly that chemical was taken back up and how fast the
Yeah.
signal would stop. So we hypothesized that people with a particular polymorphism in that DAT transporter would have more trouble with cues, that would have a greater response to the drug cues. We showed that to be true. And
Mm.
we replicated that, which doesn't often happen in the brain imaging field. It's difficult. I don't know if we got lucky or what.
Yeah.
And then we
Yeah.
started using medications with, um, with mechanisms that we thought would help with cue reactivity. And the first one we tried was baclofen. Have you heard of baclofen?
Hmm.
Yeah, it's a
No, I have
medication
not.
that is.
Mm-mm.
Oh, okay. It's used. It's actually approved in Europe for alcohol use disorder. It's not approved in the United States,
Okay.
but
Hmm.
it's used off label. We found that it really helped certain subgroups of people, blunting this brain cue induced brain activity, as well as the subjective, reports of craving that went along with it. So, how did it do that? It sort of blunted the activity in these limbic regions, and that those studies are all published. And then we looked at a medication called Chantix, which you may have heard of. It's varenicline.
Hmm.
It's a smoking cessation medication. In fact, it's the number one. It's probably the best smoking cessation medication. So we used that and examined the brains of people while they were seeing these cues, and basically showed that varenicline activated these cognitive control regions and
Oh.
also could blunt some of these limbic regions. And so we kind of showed the mechanism of action of varenicline. There's other things that we've noticed throughout our work. We noticed that there's sex differences in how people
Okay.
respond to
Hmm.
cues, but that it
Hmm.
seems to be modulated by hormones in women. So if you just look at
Okay.
men and women and show them these smoking reminders, we don't see that much difference in the response. But if you look at the influence of estradiol or and progesterone on these responses, there is an influence of estradiol. So our latest set of
Hmm.
experiments are looking at women who are naturally cycling. They're not on birth control or taking any kind of hormone, and we brain image them over the course of 3 menstrual cycles. And during this time, we image them at a time of the menstrual cycle right after they get their period, when the influence of hormones is very low. And I can provide some pictures for the post for this, because it's a little tricky to understand. Yeah, and
Hmm.
then we image them again when estradiol is high, and that's the time of the month when women are, anthropologically speaking, more receptive, because that's right before ovulation. And
Hmm.
the animal literature shows that they experience more reward during that time of the cycle.
Right.
They will pump harder for drug, for example. And that's an animal model that they are experiencing more reward from the drug. They want the drug more. So, and then we also image them during the luteal phase later in the cycle when progesterone is higher. And so then we compare their brain
Hmm.
responses across these 3 like prime time points of the menstrual cycle. And we have shown, and this is not published yet, but it's been presented at conferences, that during high estradiol, women have much stronger responses to the smoking cues. But
Wow.
we also
Okay.
saw variability here. And so, what was that variability? Well, we still had that dopamine transporter variability that popped up.
Mm-hmm.
So,
Mm-hmm.
we now have what we describe as a smoking cue vulnerable endophenotype in women, which is basically if they are have this particular variant of the dopamine transporter, and during certain times of their cycle, they are really just don't have that much protection against smoking reminders
Okay.
compared to some
Mm.
women with this other variant. And so we're still studying that. We're trying to find out how to help these women, you know. Um,
Mm-hmm.
it's probably, possibly true, and some people are studying this, that we can treat them with progesterone. Um, Progesterone seems to have a
Okay.
protective effect on drug related behaviors. So that's one avenue. Another, it's, I can't talk much about that because we haven't gotten to that point yet. But
Okay.
that's kind of like the gist of the research, is really delving
Mm.
in and trying to find out individual variabilities in response to
Yeah.
medication, and treatment, and what do people need.
Right. I mean, that was amazing. What an amazing story, and I'm so sorry about your brother. But obviously it's triggered this fantastic line of research that you're working on now. So I have a couple of questions, and possibly quite naive questions. So you talked about the brain. Having, so you have the synapse, the synapse that is, bracketed by these two neurons, that one releases, substances like dopamine and the other one receives it. And in the case of addiction, you have this massive amount of dopamine that is pumped through, that the brain doesn't know what to do with, ergo basically evolves, I guess, to decrease the number of receptors on the receiving end. And so then what happens after that? Because if you have withdrawal, correct? I mean, doesn't the brain think, all right, now I have too little dopamine, so maybe I should actually increase? So what is the brain, what does the addicted brain look like in terms of what is the mechanism of this, of withdrawal, for example, and of, recovery? What does that look like?
You can think of it you can think of it in simple terms, I think, like growing a muscle that you haven't used for a while.
Mm,
It's not an overnight thing. It's not going to happen in a week. It's not going to happen in 2 weeks. It's not going to happen when, let's talk about cannabis withdrawal, which includes a lot of lucid dreaming and insomnia and irritability. That stuff can go away in as little as, a week or two, and sometimes sooner for some people, and maybe a little bit longer for other people, depending upon how much marijuana you consumed and other things about you. But it's not going to, you have to fill your life and your brain with new experiences that strengthen the dopamine
uh-huh.
pathway. So
I
if you
understand.
just don't do anything and you don't change your life and you don't get treatment, and whatever that treatment is for you, it can be, psychosocial treatment, it can be cognitive behavioral therapy, it could be medication, it could be a combination of all those things. For most drugs of abuse and drugs that get us addicted, we have a bunch of medications that do work, but they don't just work for everybody. You have to find the one that works for you, and you have to have a treatment team that helps you get there. And those are barriers.
Right.
Those are barriers because
Okay.
people with addiction often have gotten themselves to the point where they don't have a job, they don't
Yeah.
have a
Hmm.
family
Of
support
course.
system, they don't have money to get proper treatment, they don't have, they're so depressed, they don't have the energy to do it, they also don't trust that they
Right.
can do it. One of the biggest, there's stigma involved. They don't want to admit that this happened to them. So there's self stigma, and there's stigma of the medical profession against people who have, and they don't,
Yeah.
stigma is something that's really, really, really challenging. But the two biggest obstacles that I see are,
Yeah.
and I'm talking about the United States. I don't have as much information about the rest of the world. But the United States doesn't have a good safety net for folks that are struggling like
Yeah.
this. In my view,
Right.
medications to treat addiction should be free. Doctors should be taught how to treat addiction, and they're not trained. They will tell you this, that they're not trained. I think the
Mm.
psychiatric doctors with also who specialize in psychiatry have a little bit of training, but not that much. And these folks have a special illness, just like diabetes, high blood pressure, heart disease,
Yeah.
anything else. It's an
Mm-hmm.
illness that requires
Mm-hmm.
training. And without the training, the doctors
Sure.
don't know what to do with these medications. We've got, for example, for
Yeah.
opiate addiction, we've got several medications that work. We've got methadone, we've got
Yeah.
naltrexone, we've got buprenorphine. These medications, if a doctor knows how to administer them and prescribe them and work with the patient, they've got proven efficacy, you know. But how does a person get that medication? That's the hard part,
Yeah.
in the United States anyway. I think I can't really speak for the rest of the world. But I want to learn
Right.
more about that because we need to get some of those strategies that I know are going on some places and bring them over here. If I ran the world, medications, all medications would be free. If you need a medication, you should
Right.
be able to get it.
Yeah.
Because in the
Yeah.
long
Yeah.
run, it saves the government money, you know,
Yeah.
um,
Yeah.
and everything's really all
So
about money. So.
it is really about money. Yeah. No. I was just wondering, like, in terms of, so we talked, you talked about the SNP that creates the transporters, whether they are, less or more, in different people. So that is sort of, and then you have this, of course, this hormone connection that you mentioned as well. If you have to look at these two factors, and probably there are, of course, more factors because you talked about variability in different people, can you actually predict, I guess, just of who could be more prone to addiction if they were exposed in the right to a substance or something like that in the right circumstances?
That's such a good question. So one of the reasons that it took so long to um, identify and accept addiction as a disorder slash disease is because there's no biomarker thus far.
Yeah. Hmm.
And that's what you're asking me. If you have this biomarker, do you have a propensity to become addicted? So in the case of my family, for example, um, you know, out of 5 siblings possible, a half brother that I found out, because there was so much addiction in my family, it's a mess. My mom left us kids early, but I found that there's a half brother she had before us. He died of alcoholism. There's a half sister after us
Mm.
who, if she's still alive, had severe cocaine addiction. Out of the three of us, my two brothers and I, um, my brother died of addiction. I was severely affected, and my life was severely affected by cigarette smoking, which I have been able to quit smoking for many, many, many years. But I can't have a cigarette, and I know that.
Yeah.
And luckily, my training,
Yeah.
what I do, it gave me a lot of insight about addiction, of course, especially nicotine
Yeah.
addiction and cigarette addiction. And I know that I can't have a cigarette, but my other brother John doesn't seem to be affected at all. And we all had the same
Yeah.
upbringing, similar upbringing. I think my older brother experienced more trauma because he was older when my mother left. He was 6 years old and we were younger.
Yeah.
And we all have the genetics. And, then how early did we start? I had my first cigarette when I was 11 or 12 years old. I was very young. And
Wow.
that's
Wow.
that's a bad thing. It's going to change my brain. And my
Yeah.
brother John, I do not think that he smoked, so he never had a problem with cigarettes.
Yeah.
He somehow escaped the the grips of addiction. But
Yeah.
there's a lot of families that I know of where one family member is severely affected, whereas many of the other family members don't even use drugs. They're not even interested in them, or alcohol, or cigarettes, or anything else. This it seems to strike, but we do know from the science that it is genetic and that these other factors are important. It's almost as if people have, and you've met people maybe like this in your life, who have a decreased response to reward. They start off that way.
Yeah. Mm.
They draw a picture when they're 5 years old and they go, oh, that's terrible. I hate my picture. And the other kid
Mm.
has a picture that's, and they love their picture. They got reward from doing that picture. So, it's
Yeah.
already like there's some deficit there. And you know, it's sad. It's sad that, but we're trying to find out ways to help these people, and the earlier we can help them, the better. And
Of
what I
course.
think is
Yeah.
really important that I, would stress if I was a psychologist, but I'm not. But what I would stress to people is teach your kids about addiction. If you drink or smoke or did in the past, tell them there's a family component, there's a hereditary component, and please just try not to touch it until you're 18 or 21. I used to tell my kids, don't smoke, please don't smoke until you're out of high school. At least do
Yeah.
that for me. Just wait until you're out of high school.
Yeah.
And so
Yeah.
the older you are, the more chance the brain has to get a solid foothold on that dopaminergic system,
Sure.
even if you've
Yeah.
already gotten, already have a sort of a deficit, you can strengthen it.
Yeah.
That's just purely my
Well,
thoughts. No science
well,
there.
one of the things that no, well, of course. But one of the things that was really interesting to me was what you're studying, of course, right? The fact that you can actually have a cue and create a response of dopamine without even actually having the drug in your system. Now, does it actually, like I said, again, a naive question perhaps, but does it work the other way around as well? So let's say, for example, if, something gives you that dopamine rush, and just the thought of it, can we actually use that somehow? Because I'm pretty sure that we all need a dopamine rush on cue that does not actually involve an addictive substance, if you know what I mean.
Exactly. Yeah. Well, I mean, that's what motivates us to do anything. You know, um,
Mm.
just sitting here talking to you is giving me a dopamine rush. I mean, yeah, it's something that we need. It's why we have connections,
Yeah.
social connections with people. It's why our puppy dogs and kitty cats and, everything that we love in life,
Oh, yeah.
growing flowers, we
Yeah.
need it. That's why this is so hard to treat. We can't just turn off the system or we turn off the person.
Yeah.
And
Hmm.
that's what we
Yeah.
tried many years ago with people who had substance use problems. We used to try to turn off the dopamine system. And in fact,
Yeah.
some of the schizophrenic medications do that. They turn down that dopaminergic system so much that people who have schizophrenia don't want to take their medication, because then they have no
Yeah.
life. They're not excited by anything.
Yeah.
So we have to be real careful with this system. It's a delicate balance, and that's one of the reasons I love baclofen is because it's a pretty mellow medication, and I have to reiterate, it doesn't work for everybody. We wouldn't get out of bed in the morning if we didn't have dopamine. There'd be no reason, you
Sure.
know.
Yeah. Yeah. Fair enough. Fair enough. So, can I ask you something a little bit different here at this juncture? We were talking about, like, I've been looking at stories where people have been now researching using drugs like MDMA for treatment of psychiatric disorders like PTSD. What do you know? Do you know anything about that? Can you comment on that? I mean, is that it seems to be it seems to be an amazing thing to be looking at, but also, of course, everybody's like, oh, MDMA, that's a drug, you shouldn't be using it because it's addictive, et cetera, et cetera. But yeah, do you have any comments on that kind of research?
Well, the first thing that comes to my mind is it would be great because you can use those types of substances to get into the psyche, and they've shown that you can do that, and people can drum up things and
Hmm.
and work through issues. And we could say, well, you can't use that therapy, but we don't. So anyone who engages in that is taking a risk, worth the risk to
Yeah,
do this because their life circumstances are so bad, or
fair
they really
enough.
need to, they're
Yeah,
struggling. um, I know people who have done it, worth the risk to do this because their life circumstances
yeah,
are so bad, or they really need to, they're struggling. If it's provided by a medical professional who knows what they're doing and the person understands their risks, I think it's an individual choice, but you have to be
yeah.
educated,
Okay, fair
you
enough.
know.
Okay,
And
fair enough. Yeah. Well, Terry, it was such a nice pleasure to talk to you. I know that you wanted to also talk about your journal that you are editor in chief of.
yes, so very excited about this new journal. It's called Drug and Alcohol Dependence Reports. Got the same sort of goals, and we accept the same types of research, and you can read all about us. I'll put the links in the post. And we like to think of ourselves as being more diverse, or we're really trying to improve our diversity, I should say. And we're using various techniques to do
Hmm.
that, which will, since we're brand new, I can't talk about them yet, but we will be rolling out some new. Sheba helped us with some things, actually. um, and yeah, and we are also interested in more nuanced research that maybe might be more focused and more pilot. That so if you've got that kind of research that you would think might not make it into a top tier journal, send it our way. We have. It doesn't mean we don't have strict requirements. We do, and we're going to be indexed very shortly in PubMed Central, which is really
Hmm.
important for scientists. They want to submit to. I think within 3 or 4
Yes, of
years we'll
course.
have an impact factor,
Hmm.
and like I said, we will be indexed on PubMed by probably July or August. I would say. I think within 3 or 4 years we'll have an impact factor, and like I said, we
Okay.
will be indexed on PubMed by probably July or August. I would say. So PubMed Central.
Wonderful.
And it's really a fun job. It's really fun to have this kind of impact on what kind of science gets published. I can't tell you how
Hmm.
much fun I'm having. It's really, really fun. Stuff that I know,
Wonderful. Wonderful.
that maybe might not make it into one of the top journals or even any journal. And I go, oh my gosh, that's so interesting. And that's so
Yeah.
important. We're publishing stuff right now, a lot of stuff on, you know, uh, stigma, as well as because there's a lot of new
Mm.
initiatives coming out. COVID has opened up a whole new chapter, I
Yeah.
think, for
Sure.
addiction research. I think one of the great things that's come out of COVID, not to change the channel, but I know we're running out of time, is
Hmm.
what like continuing treatment, and even treatment and continuing treatment through virtual, Zoom, for
Yeah.
example. Um, it's so much easier for people to continue treatment when they can talk to a doctor through Zoom, or they can get a phone call 3 or 4 times a week, or they can have an app on their
Yeah.
phone. There's all these virtual apps now where they can monitor their behavior, or get help really quick when they are in a craving situation. All this stuff has just blossomed, and the science is starting to come out, and we've shown that it works. So telemedicine is working. Virtual appointments with docs and medical professionals is working.
Yeah.
And
Hmm.
in the past, people just sort of felt lost because they have their stent in treatment. And to be honest with you, only about 10% of people who have problems with addiction get treatment for a million reasons.
Right.
But only, out of
Yeah.
those 10%, most of them, when the treatment is over, they're not healthy yet. They still need help,
Yeah.
and they're not getting it. And through these new avenues of, apps and smartphones and virtual meetings, they are able to continue their treatment. The
Mm.
barriers, the transportation barriers, the family responsibilities, all those things can take a back seat because they can go up in their bedroom and open up their computer or open up their phone and get help. So I
Yeah.
love that.
That's
That's
wonderful.
yeah.
Yeah, that is absolutely wonderful. I mean, I think that it is literally a matter of like making sure that people get the help that they need. And you're absolutely right. I mean, because of COVID, there is. I mean, I know personally somebody who actually develops these apps, medical apps, and I think that that is really, really important. I mean, in the Netherlands, for example, I mean, I know that we have a deficit of first line psychologists that basically see the patients first before they get referred to psychiatrists. So definitely, these kind of problems I think exist all over the world, and at least there is something that helps them through their day, because you never know. I mean, anybody who's suffering from a mental illness knows that there are good days and then there are bad days, and if you can
And
actually
good
talk to
moments
somebody or
even.
actually just put it in an app.
Yeah.
Yeah, exactly, good moments
Yeah.
even. So that's
Yeah.
that's so great. Terry, it was such a pleasure talking to you. Thank you so much for your wonderful story. I mean,
You
I
are
know it got
welcome.
emotional at some point, but I think
Yeah.
it's it's such an amazing work that you're doing, and I'm pretty sure that there are people out there that are very thankful for your work. So thank you so much for that, and thank you so much for talking with me.
Oh, thank you. It was my pleasure.